Hello, my name is Bill John Ganancho, student of physical therapy at the University of St. Augustine. I'd like to start by thanking you all for attending my presentation. Today I'm going to share with you a case involving a patient presenting with chronic on and off low back pain. According to Anderson et al. From the Musculoskeletal Science and Practice in 2007, low back pain in long-standing workers has many antecedents. However, ergonomics relating to fatigue and discomfort are most heavily implicated in this population. The purpose of this presentation is to identify tissue-specific impairments that are contributing to her pain, as well as generate a strategic evidence-based intervention program to address them. My patient is a 28-year-old female, right-hand dominant with an endomorph somatotype. She began to experience this lumbar pain 5 years ago working as a front desk manager at a hotel. The patient did not seek any medical attention to address the issue, as well as did not undergo any diagnostic imaging. According to Marco et al. In the Academic Emergency Medicine from 2006, the numeric pain scale rating has a high validity value in which the patient rated her pain from 0, which is no pain at all, to 10, the worst pain. At worst, the patient rated her pain at a 5, and at the best, she rated her pain as a 1. The patient's chief complaint is diffuse and dull, achy pain in the lumbar region at midline while standing or sitting for an extended period of time. The activities that would make it worse included prolonged sitting or standing for more than an hour. Some things that the patient does to reduce the pain include stretching, placing a hot pack on the low back for 10 minutes, and constant low-impact activity, such as walking. She takes basic over-the-counter medicine such as Tylenol in the events that the pain is too unbearable. Additionally, the patient's past medical history is unremarkable. The outcome measure that I decided to use for the patient was the Oswestry Low Back Pain Disability Questionnaire, which is an assessment of daily functional activity. According to Hallfaker et al. In Pain Procedures in Clinical Practice from 2011, the ODQ is a 60-item test which assesses the amount of restriction pain imposes on 10 domains that includes pain intensity, personal care, sleeping, etc. Each category is scored from 0, which is no impairment, to 5, which is maximum impairment. There is a final tally which ranges from 0 to 50, which is then multiplied by 2. The patient ultimately scored a 20% on the Oswestry scale, and that indicates minimal disability for her. Ultimately, the patient's goal is to be able to tolerate a full work shift of 10 hours without pain at the end of the shift. I'd like to highlight some objective measures that I obtained, beginning with structural inspection. The patient presented with rounded shoulders, decreased kyphotic curve, and slight anterior pelvic tilt. In active range of motion, patient presented with normal range of motion in forward bend. However, there was a dynamic reversal of the lordotic curve of the lumbar spine. However, there was a flattening of the upper lumbar and lower thoracic spine at the level of L1, L2. In left rotation, patient had limited range of motion compared to right rotation. In passive intervertebral movement testing for lumbar rotation, the patient presented with grade 2 hypomobility at the left facet of L1, L2 segment, and grade 4 hypermobility at the right facet of L2, L3 segment. I decided to also perform the prone instability test, where the patient hunches over the edge of the treatment table and feet firmly on the floor while I apply an anterior force over the lumbar spinous processes. Then I proceeded to ask the patient for their symptoms. If there is pain, then I ask the patient to actively extend their trunk and firmly lift their lower extremities while I apply another anterior force on the same processes. If the patient has pain in the first phase, then has less or the same level of pain with the contraction of the erector spinae muscles in the second phase, then the patient proves to be positive in the prone instability test. For my patient, she was positive for this test, which means that the patient would be a good candidate for a lumbar stabilization program. After doing a neurovascular screen, it was found to be unremarkable. Additionally, I decided to perform the supine to sit test to account for a possible anterior or posterior rotation of the ilium on either side. In this test, the patient began in supine position while I visually noted the level of the inferior pole of the medial malleolus. Then I passively flexed bilateral knees and hips to end range in order to reset the hips to a normal resting position for standardization. After I lowered bilateral extremities until straight into a supine position, where I then asked the patient to sit in a long sitting position. At the end, if one leg appeared longer at the start, it could indicate an anterior rotation of the ipsilateral ilium or a posterior rotation of the contralateral ilium. The patient was positive for possible anterior rotation of the right ilium or possible posterior rotation of the left ilium. After palpating for tenderness, I found hypertonicity in the erector spinae muscle group, more on the right side than the left side, which could indicate a compensation of the global musculature of the vertebral column as a result of instability. I screened the strength of the transverse abdominis by using a pressure biofeedback unit such as a blood pressure cuff to assess proper functioning of the transverse abdominis. Patient lay supine with the cuff placed on the low back of the patient. The cuff is then inflated to 40 millimeters of mercury while patient lays on top of it. According to Grooms et al. In the Journal of Orthopedic and Sports Physical Therapy in 2013, appropriate function of the transverse abdominis should reflect using the drawing in maneuver while holding the pressure at 2 to 4 millimeters of mercury above the 40 millimeters of mercury baseline, 2 times consecutively for 15 times each. Ultimately, my patient was unable to perform this. My PT diagnosis includes low back pain with movement coordination impairment and low back pain with mobility deficits. Ultimately, the PT long-term goal, in 6 weeks, the patient will maintain proper posture throughout her work shift in order to maintain a pain level of 1 to 2 out of 10 by the end of the night. And as far as the impairments goes, I would like to address in order the hypomobility of L1, L2. In order to address this, I would perform joint mobilizations. According to Reed et al. In the Journal of Canadian Chiropractic Association in 2014, a large amplitude at end range spinal manipulation in conjunction with myofascial release yielded efficient results in resolving hypomobility much faster over a 3-month period. Secondly, I would like to address the tightness of the erector spinae muscle group. I would perform myofascial release for this. According to Arguisuelas et al. In Clinical Biomechanics in 2018, there was a significant reduction in pain and disability and a normalization of flexion relaxation response in those patients who did not show myoelectric silence before the intervention. Thirdly, I would like to address the weakness of the transverse abdominis muscle. I would perform exhalation exercise in conjunction with the use of a blood pressure cuff to monitor the progress. According to Hodges et al. In the Journal of Physical Therapy Science in 2016, respiratory muscles are an important factor affecting spinal stabilization. In particular, if respiratory and abdominal muscle activities are uncertain, spinal stabilization will decrease due to decreased intra-abdominal pressure. Lastly, I would like to address the leg length discrepancy. I would apply the use of an orthotic such as a heel lift to address this. According to a study by Fulman et al. In Preventative Medicine in 2004, it was found that viscoelastic shoe inserts reduce low back pain in approximately 80 to 85% of 96 women who spent long hours standing in their occupations. The prognosis for the patient is good due to her age, her healthy, active lifestyle, and the motivation that goes with it, as well as her socioeconomic status, which shows her ability to have access to the proper equipment and tools to achieve her goals. This concludes my presentation. I'd like to thank you all for being here.